Everyone deserves to have an endocrinologist fully understand all of the amazing metabolic processes that our bodies are performing. I'm Dr. Lindsay Van Dyke, and this is the Endo Days. It's Dr. Van Dyke, and this is part 2 of State of the Heart in America. I'm here with my friend and colleague, Dr. John Osborne, a Dallas cardiologist with over 2 decades experience in managing heart disease. We have been discussing heart disease in this country, who has it, and how aggressively it can kill. Now we're going to explore how we check for heart disease in this country and what we do about it when we find it. Then we want to get a little more radical and discuss what the vast longitudinal amount of evidence shows us we should be doing to check for heart disease and treat it, even though that is not necessarily reflected in the current guidelines. Guidelines are just that, a guide. But patients and some doctors don't realize that there are more than 20 different professional societies that all offer recommendations about cholesterol. And the really fun part is that they all are pointing doctors in slightly different directions. So, John, how would you navigate that?
It's very hard. It's confusing to everybody. It's confusing for physicians, let alone patients, to try to navigate this. But that's part of the reason why we're doing this. I always like to tell my patients, if you quote me, date me, and this is science, it constantly changes, then I say, whatever I tell you is the truth, whatever you hear from somebody else is opinion.
That's a good point. I will start using that. So in general, how are people being screened in the United States right now?
So historically, and this goes actually back to the post-World War II era, we did some large trials called the Framingham study and others that were epidemiological studies. That is, we just look at a cohort of people, a group of people, generally living in a certain part of the country, and then ask the question, how did they end up having heart disease? And from that, we found the concept or the ideas of risk factors for heart disease. And we've probably all heard of these, but those include, of course, tobacco use, diabetes, high blood pressure, high cholesterol, family history, all of which play a role in contributing to heart disease. From that, we then got quantitative. So we understood that these were the categorical factors that underpinned heart disease. Then we said, okay, can we calculate a number that incorporates all of those different factors that gives us an idea of one's risk of heart disease over generally about 10 years? You're at very low risk, you're at intermediate risk, or you're high risk or very high risk.
So we use these calculators all the time, but there's not just one. There are a bunch of them.
Yes, there's multiple.
And what limitations do they give us?
So the limitations are that they are population-based tools. So in other words, we're deriving this from a population, and they're going to give us an insight about a population. Then the problem is we're going to try to apply that to an individual. So that's always been the problem of conveying population data to an individual, trying to find out what's going on with them. As an example, if you had a bad family history of colon cancer, we know genetics play a big role there. I have a calculator that takes into account family history, age, etc., and I come up with the fact that this colon cancer score says you're at very high risk. But that doesn't mean you have colon cancer or polyps, or you don't. It just means that you are at high risk. Well, we don't do that. What we do is everybody gets screened. You look at their colon. If you're normal, you come back in X number of years. And if you have polyps, 10 years. And if you have polyps, then we take care of those polyps, and then we follow you more carefully. So we don't base our decision on a risk of colon cancer. It's based on whether you actually have early precursors to colon cancer. These polyps is actually a pretty good concept that I think we should be using in the world of cardiovascular disease. And I think that's kind of actually where we're headed.
So let's go from population-based calculators to the individual risk and try to break them down on an individual basis. What are the components that matter to you when you're trying to figure that out, and which ones are the most important ones?
Sure, there's a whole variety. Family history, really important. In fact, I would say anyone who wants to know what your risk of heart disease is should be asking you about family history. Mom, dad, brothers, sisters. That data can be sometimes very, very helpful, particularly if they're males younger than 55 and women less than 65. That should be a major red flag and important because you may have inherited a predisposition towards heart disease. Of course, other conditions are also very, very important as well. Diabetes, very, very big factor. factor in heart disease. In fact, diabetes, of course, many people think of it as a blood sugar disease. As I view it as a cardiologist who specializes in vasculature, I view diabetes as a blood vessel disease. High blood pressure or hypertension, also very important. Probably high blood pressure is the single most common cardiovascular disease. Only 50% of adults in the U.S. have high blood pressure, so it's extremely common and another big factor in heart disease. There are pro-inflammatory states, both genetic and acquired. Of course, tobacco use, and in fact, I would argue any tobacco use, so I don't just say smoking. I think any tobacco it gives you a pro-inflammatory state, as well as sedentary lifestyles, bad diets, processed foods, high-carb diets, low-fiber diets. All of those things are very important as far as contributing to the development of plaque. Ethnicity plays a big role too. There are very different effects and rates of high blood pressure in African Americans versus non-African Americans. Also, diabetes, different rates. Hispanic populations versus non-Hispanic. Another population that is woefully affected by cardiovascular disease early on are the South Asian population. They have high rates of diabetes and high rates of heart disease. So there is an unequal playing field with respect to ethnicity, and body composition also very important too. Lean muscle mass, as we call it, and body fat also play a role, that can be both genetically determined as well as, of course, influenced and affected by lifestyle. And then, of course, diet. By the way, the simple way to sort out saturated fats are defined as those substances which are solid at room temperature. So saturated fats also play a role in elevating cholesterol and contributing to heart disease.
What do you have to say about coconut oil? Because at a normal room temperature, that is solid, but it is touted as this miracle health cure for about everything.
Yeah, I have to be very cautious about that. I'll give you an example. So we have all heard a lot about coconut oil as being a magical thing, but I will tell you that coconut oil is actually one of the tools we use to generate models of atherosclerosis in animals, and obviously that's pretty concerning.
So the American College of Cardiology published new guidelines for cholesterol management just a few months ago, and those were updated recommendations compared to those that were published in 2013. What's your feedback on the new guidelines?
So I have to tell you, I was actually there at the American Heart Association meetings back in November when they brought out these new guidelines. The last ones were from 5 years ago in 2013. The 2018 guidelines that were developed by the American Heart Association, American College of Cardiology, but also in collaboration with a whole bunch of other groups. So that issue that you talked about before, we have multiple different groups saying, do this or that, and many times not all the same. We in medicine kind of came together pretty well. And in fact, the National Lipid Association, American College of Obstetrics and Gynecology, many other organizations all came together on these new guidelines. So they really are a voice that cuts across multiple different specialties. So I think they're a big advance, and they've also introduced a few new points and brought out some new tools that we should be using on a more routine basis.
What do you think is still missing?
One of the areas, and this is all very dynamic, they don't spend a lot of time talking about triglycerides, one of those other fats that I think we're going to be focusing a lot more on triglycerides and triglyceride treatments. But I think the 2018 guidelines I'm very happy with.
Okay, so every set of guidelines has primary recommendations like lifestyle, get exercise, don't eat saturated fats, etc., etc. And then they all have these adjunctive recommendations. And some of those are these inflammatory markers we draw in our lab tests. Can you talk about those and why you find them useful?
Sure. So some of those other adjunctive tests or additional testing that we can do to better refine our understanding of your risk, but also give us targets to shoot for. One of those is something called HS, or highly sensitive CRP, or C-reactive protein, or HSCRP. So this is a tool to measure inflammation that we were talking about earlier. Has been very well validated in really hundreds of different papers that that understanding one's inflammatory status adds additional value. It gets back to that idea of, do you have sticky vessels or vessels that are more like Teflon? Another marker that's more on the cholesterol side is another lipid marker called LP little a, or lipoprotein little a. One of the troubles with this LP little a is that we know that it's a bad actor. If you have high LP little a levels, it will increase your risk of strokes and heart attacks anywhere from 5 up to 11-fold. So it is important. Here's the problem with LP little a. We don't have a specific treatment. If you are found to have high LP little a, that will occur in 20% of patients with heart disease. Now, the good news is, in the pipeline, there are drugs and tools to be able to substantially lower LP little a by up to 80 to 90% that appear to be fairly safe and effective in early studies. But I think that's going to be an area that will continue to be of very great interest.
So what can we do for people who happen to have an LPA that's off the charts?
So right now, we have certain goals and guidelines for dropping the LDL cholesterol, the bad cholesterol. If we also know you have high LP little a, we'd probably say we need to be even more rigorous and more aggressive about dropping your LDL cholesterol, because that we can easily treat.
So you commented on people with higher risks and inflammatory markers. You want to drive that LDL down. How low can you go?
We have studies where we've driven the LDL cholesterol, which, by the way, average LDL cholesterol in U.S. adults untreated is about 130, to give you perspective. We have studies where we've driven that LDL cholesterol down to an average LDL of 30, and in fact some of these patients are well below 30, that seem to be well tolerated. And actually, if you look at people who had very, very low LDLs, that the net benefit actually seem to be amplified as we drop that LDL further.
So on a different topic, I have become a very strong proponent for the use of the coronary calcium score when I am screening and evaluating patients' personal risks. And we have so much data about its impact on cardiac outcomes, even in young people. Can you talk about that?
Absolutely. So I also share your enthusiasm and excitement about the coronary calcium score. So calcium score is not a blood test. What it is, it's an imaging test. So we take an individual, we put that individual into our CAT scanner. There's no contrast. We don't put in an IV. It takes just a few minutes to do. And these calcium scores, so we've really been doing this for about 30 years now. And we've begun to realize that these tools are very useful in people without symptoms to identify the early atherosclerosis, the early plaque, long before you ever have symptoms. So the way I like to think of the calcium score and explain it is, I think of the coronary calcium score as the cardiac colonoscopy. That is a tool to pick up the polyps, if you will, long before you develop cancer. And in fact, with these new guidelines that we alluded to, they now really emphasize the role in people without symptoms that we call primary prevention, who have not had balloon stents, bypass surgery, heart attacks, that are walking around feeling fine, to really emphasize the use of coronary calcium score in these individuals who are at what we call intermediate risk. Most of us fall into what we call intermediate risk. And in fact, the calcium score is really proven to be an extremely useful tool to be able to take a population at intermediate risk of heart disease, and if their score is 0, it means their next several years' risk of heart attack is very, very low. Conversely, if they have a non-zero score, if we see any calcium in the blood vessels, their risk is actually quite dramatically elevated.
So if it's so useful, why aren't we seeing everybody using it all the time? Because so many people are intermediate risk.
Absolutely. I think there are many people, myself, I've kind of been on that bandwagon for a long, long time, but medicine moves very slowly. It moves glacially, as I like to say. And at least finally in 2018, we're going to see a lot more use of the coronary calcium scoring. The way that we take the pictures and analyze and score the pictures has been standardized since the 1990s. So I think you're going to see, when you go start seeing your doctors going forward, I think we're going to see much more of a discussion and recommendation for using coronary calcium score, which I think is a fantastic evolution.
Now, some insurances pay for it, some don't. It seems to be payer dependent or state dependent or both. But out of pocket, it's not expensive.
It's relatively inexpensive, I think, for the condition that only kills 40% of us and shows up as sudden cardiac death in half of men and 2/3 women. I think it's a pretty inexpensive test. At our facility, it's about $60, but generally in the Metroplex, you're going to pay easily sub $100, maybe as low as $50. The bang for the buck that you get for early detection of heart disease, it's a great deal. I like to call it a 4-year warranty. So if you're 0 and you eat right, exercise, don't start smoking in the meantime, that you don't need another one for 4 years. It's $60 divided by 4, which means, it's $15 a year, or as I like to express it, 3 cappuccinos from Starbucks a year for a test that gives us an insight about the disease that only kills 40% of us and gives us a heads up. Or conversely, I run into lots of people with a bad family history. They're worried about heart disease. They get a 0 calcium score, and I can tell them, you don't have to worry about this anymore.
So when I first became acquainted with the coronary score, I was in fellowship training in Albuquerque, and they would tell us that people would complain to them about the extra exposure to radiation, but the amount of radiation that they would give in that test was the same as anybody living in Albuquerque for 3 months. And I lived there for 2 years. So I'd say go for it. Don't go to the movies one night and then go get your coronary score.
Absolutely. The radiation that you're getting is about the same as a mammogram.
So we have reviewed the standards of screening and diagnosis and explored some of the tests we can perform in adjunctive ways to further assess the severity and extent of heart disease, and how these results may intensify treatment goals. But in part 3 of State of the Heart, we are going to dive into the world of medical treatment and explore some controversies that still exist.